Picture this. A patient is right in front of you, and they can't breathe. I mean, they really can't breathe. Every single second is a fight for air. The clock is ticking. It is one of the most intense, high-stakes situations in all of medicine. And there's a procedure designed to take control of that chaos, to turn the tide.
So what actually happens in those critical moments, when a patient just can't get a breath in? How do clinicians step in, take control of their breathing, and literally save their life? That's exactly what we're going to get into in this explainer.
All right, here's our game plan. First, we'll talk about why this is such a big deal, a real fight for air. Then, we'll walk through the 7 Ps of RSI, which is the step-by-step playbook. After that, it's all about making sure the job's done right, proof of placement. We'll also touch on the dangers, what can go wrong, and we'll wrap it all up with the life-saving takeaways you've got to remember.
Okay, so first up, a fight for air. Let's start at the beginning. Why is intubation, securing a patient's airway, so incredibly critical? Why is it one of the most fundamental skills in all of emergency medicine?
So what is intubation, really? Well, at its core, it's all about taking control. A tube gets placed right into the trachea, that's the windpipe. And this does 3 incredibly important things. First, it creates a secure highway for air to get in and out. Second, it lets a machine, a ventilator, do the breathing for the patient. And third, it stops anything from the stomach from getting down into the lungs, which is a really big deal. And this right here, this is the whole philosophy behind it. It's like the golden rule of airway management. When in doubt, intubate early rather than crash late. It's all about being proactive. You don't wait for a total disaster. You get ahead of the problem and take control before things fall apart. Okay, so how do they know when it's time to pull the trigger? Well, there's this really handy mental checklist they run through, the ABCDEs. A is for airway. Is it blocked, maybe from facial trauma or swelling? B is for breathing. Is the patient's oxygen super low, or are they just getting exhausted from the work of grieving? C is for circulation. Are they in shock or cardiac arrest? D is for disability. We're talking seizures or an overdose. And E is for expected deterioration, things like severe burns where you just know it's going to get worse. Now, this is a huge one, a real exam pearl. It's all about the GCS, or Glasgow Coma Scale. It's just a simple score for how conscious a patient is. And the rule of thumb is pretty famous. GCS of 8, intubate. It's that simple. If their score is 8 or less, it's a pretty sure bet they can't protect their own airway, and you need to step in. So, we've established the why. Now for the how. How do you manage all this chaos? Well, there's a very specific, standardized playbook called Rapid Sequence Intubation, or RSI. And what it does is pretty amazing. It takes a totally frantic, high-pressure moment and turns it into a calm, controlled, step-by-step process. And here they are, the famous 7 Ps of RSI. You've got preparation, pre-oxygenation, pre-treatment, then paralysis with induction, positioning, placement of the tube, and finally, proof of placement. It's a roadmap to success, really. Following these steps just makes the whole thing so much safer. So let's look at those first 2 steps, which are all about building a safety net. Step 1, preparation, is common sense but crucial. You call for help, check your equipment, especially suction, and you have a backup plan. You always expect it to be difficult. Then step 2, pre-oxygenation. This is so important. You give the patient 100% oxygen for a few minutes to basically fill up their lungs with a reserve. It buys you precious time. Okay, skipping ahead to step 4, this is the medication step, paralysis with induction. Basically, you give a sedative to make the patient unconscious and a paralytic to relax their muscles. Your standard combo is etomidate, which is great for keeping blood pressure stable, and succinylcholine, a super fast-acting paralytic. But let's say your patient has really low blood pressure. Then you might reach for ketamine instead. It's all about picking the right tools for the job. All right, now we're at the main event. Placing the tube. First, you've got positioning. The goal is to get the patient into what's called the sniffing position. It sounds a little funny, but it lines up the airway perfectly. Then comes the placement. The clinician uses a special tool to get a direct look at the vocal cords, and then, very carefully, passes the tube right through them to the target depth. And what is that target depth? Well, for most women, you're aiming for about 21 centimeters at the teeth. And for most men, it's a little deeper, usually around 23 centimeters. These numbers are your starting point, your guideposts for getting it right. But here's the thing, getting the tube in is only half the job. Now comes the moment of truth. the final and maybe the most important P, proof of placement. You have to know with 100% certainty that the tube is where it's supposed to be.
So what's the best way to do that? What's the gold standard? It's this, continuous waveform capnography. It's a device that measures the carbon dioxide coming out of the tube with every breath. If you're getting a nice, consistent CO2 reading, you are in the lungs. End of story. It is the absolute most reliable confirmation you can get.
Of course, you don't stop there. You do other checks to be extra sure. You look to see the chest rising and falling on both sides. You listen with a stethoscope for good breath sounds everywhere. You also listen over the stomach to make sure you don't hear any air gurgling down there. And finally, you'll get a chest x-ray to see the tube's position perfectly. Now, this is a serious procedure, and things can go wrong. It's high risk, so being aware of the potential dangers is absolutely key to keeping the patient safe. So let's talk about the scary stuff, the complications. Okay, so what are we worried about? A big one is hypotension, a sudden drop in blood pressure. Then there's hypoxia, low oxygen, which is what everyone fears the most. And of course, there are placement errors. You could end up in the esophagus, the food pipe, by mistake, or you could push the tube too deep so it only goes into the right lung. You have to be watching for all of these, ready to fix them instantly. And this right here? This is an ICU pearl that literally saves lives. Listen to this. Most of the time when a patient's heart stops during or right after intubation, it's not because someone failed to get the tube in. It's because of hypoxia. Their oxygen levels just got too low, and that brings us full circle, right? It just shows you how absolutely critical that pre-oxygenation step is. It's your ultimate safety net. Okay, we have covered a ton of ground, so let's boil it all down. What are the absolute must-know life-saving points to remember from all this? Here you go, the ultra-high-yield memory box. GCS of 8 or less, you intubate. Need to keep blood pressure stable? Etomidate is your friend. The gold standard for confirming placement? Capnography, no question. What's the most important safety step? Pre-oxygenate aggressively. And finally, always be prepared for that blood pressure to drop. Always.
You know, when you think about it, the 7 Ps of RSI is just an amazing example of how a simple checklist can turn absolute chaos into a controlled process. It brings safety to one of the most dangerous moments in medicine. And it really makes you wonder, right? What other simple checklists like this are out there, quietly saving lives in hospitals every single day?